Efficacy of segmental re-examination of proximal colon for adenoma detection during colonoscopy, a randomized controlled trial. Introduction. Colonoscopy is regarded as the gold standard for the detection of colorectal neoplasia. Previous research has indicated that polypectomy during colonoscopy screening reduces the risk of developing colorectal cancer, CRC, and mortality. However, interval CRCs detected after recent colonoscopy have been associated with missed lesions. In addition, several studies have indicated that a significant number of polyps are missed during routine colonoscopy. As a result, 20% to 50% of patients who have undergone removal of all detected adenomas during colonoscopy screening would be expected to have advanced adenomas or cancer when undergoing surveillance colonoscopy within 3 to 5 years. In contrast, colonoscopies performed by endoscopists with higher adenoma detection rates, ADR, are associated with a lower risk of interval CRC. The ADR has now been accepted as an independent predictor of interval CRC risk and one of the most important quality indicators for colonoscopy. Therefore, it is desirable to develop a practical technique for increasing the ADR in order to prevent interval CRC. Several studies have demonstrated that there is a lower rate of protection of colonoscopy against CRC in the right colon, suggesting that patients who develop cancer after colonoscopy are more likely to have proximal cancers than distal. The proximal location of prior adenomas at baseline has been significantly associated with increased risk for subsequent advanced neoplasia. One hypothesis is that proximal lesions may be more likely to be missed compared with distal ones. This could be due to failure to fully examine the proximal colon and differences in proximal polyp or cancer morphologies. Specifically, proximal colon polyps are more often flat and located behind folds or on the inner curvature of colonic flexures and thus more difficult to visualize. Alternatively, proximal neoplastic lesions may differ biologically from distal lesions, which could result in more rapid progression to malignancy. In addition, the serrated pathway may play a role in this progression. Thus, there is currently great interest in improving polyp detection in the proximal colon. Several back-to-back studies have demonstrated that re-examination of the colon could detect more missed adenomas. However, tandem colonoscopy is very time-consuming and may not be appropriate in routine clinical practice. Several studies have also reported that retroflexion, the third-eye retroscope, full-spectrum endoscopy, colonoscope, and water-aided colonoscopy increase the ADR effectively in the proximal or whole colon. For most physicians, forward-view re-examination may be more accessible and easier to perform. Therefore, Guo et al. Developed segmental re-examination of the proximal colon in which the proximal colon was examined twice segmentally to make it more practical and to improve the proximal ADR. Mean withdrawal time is another important quality indicator. Shorter mean annual withdrawal times per physician during screening colonoscopies were independently associated with lower ADRs and increased risk of interval CRC. Longer mean withdrawal times could increase the ADR, mainly of right-sided adenomas. However, no study has ever compared the adenoma detection of re-examination with longer withdrawal times during colonoscopy. The aim of the current study was to evaluate the impact of segmental re-examination in the proximal colon on ADR and its time effectiveness compared with extending the withdrawal time in the proximal colon. Background and study aims. Interval colorectal cancers detected after screening colonoscopy are more likely to be associated with missed lesions in the proximal colon. The aim of this study was to determine whether segmental re-examination of the proximal colon could increase the proximal adenoma detection rate, ADR, and to evaluate the time effectiveness of this approach. Patients and methods. Patients undergoing colonoscopy were recruited into the prospective randomized controlled study. They were randomly assigned to the segmental re-examination group in which the proximal colon was examined twice segmentally and a control group in which the withdrawal time was extended, EWT. Detection rates were calculated and compared for all polyps and adenomas in both the proximal colon and the whole colon. Withdrawal times were recorded and compared. Results. A total of 360 patients were included in the study. Re-examination 178 versus EWT 182. The proximal ADR in the re-examination group was higher than that in the EWT group, 33.1% versus 23.6%. More proximal adenomas were detected per patient in the re-examination group, 0.54 versus 0.36. The ADR of the whole colon was similar in the two groups. Proximal withdrawal time was also similar. Re-examination 4.29 plus or minus 1.23 minutes versus EWT 4.34 plus or minus 1.3 minutes. In addition, there was no statistically significant difference in the total duration of the colonoscopy between the two groups. Conclusion: segmental re-examination of the proximal colon increased the proximal ADR and the number of proximal adenomas detected, and was accomplished easily and safely without increasing the overall examination time.